Hello and welcome to our lecture on the female reproductive system, where we're going to be going over the structure, the anatomy, and the function, the physiology of the female reproductive system. And we will find out the structure, the anatomy, and the function and the physiology of the female reproductive system are complementary. So the structure is helping the function. The anatomy is helping the achievement of the physiology. And when we compare and contrast the female reproductive system to the male reproductive system, we're going to find out that the female reproductive system is far more complex and far more advanced because it has many more functions than the male reproductive system. We've learned in the male reproductive system that the main function of the male reproductive system is to, number one, produce the genesis and the making of the male sex cells, while the second function is to deliver, to ship out and deliver the sex cells, the gametes of the male, the sperm, into the female vaginal tract. And we talked about how a defect and a failure in the processes of the gametogenesis and the making of the sperm is known as infertility. And we also discussed that the failure of delivering those sperm cells into the female reproductive system is known as erectile dysfunction. But now when we look at the female reproductive system, we will find out that the female reproductive system is responsible for, number one, the making of the female sex cells, the eggs, and also the making of the associated lubricating, nurturing fluids that maintain the health of that egg. And also the female reproductive system is responsible for receiving the sperm, nurturing and helping the sperm survive and swim its way up, help the sperm to swim its way up through the vaginal tract and then through the uterus and up into the fallopian or the uterine tubes. In addition, after the sperm that swam all its way up through the vaginal tract, then the uterus, then the uterine tube, we're going to see that the zygote is going to develop as the result of the union between the sperm and the egg. And that zygote is the first diploid cell because it was made from a one haploid sperm cell and a one haploid egg cell that fused together to give you a diploid cell. Then the female reproductive system is going to take it and nurture that zygote and enrich the zygote with blood supply full of nutrition and oxygen and all of the required material to develop. And also, it's responsible for the pregnancy. And finally, it's responsible for the labor and giving birth to this baby. And that's not the end. The breastfeeding that takes place after giving birth to this baby. It's also a part of the female reproductive system. And throughout life, the mother is constantly concerned with the care and the child rearing that takes place throughout the developmental stages that the baby goes through from an infant to a toddler to an adolescent to a young adult. So you see that the mother is constantly providing care for her child. Okay, so we must remember that the two sexes, males and females, are indistinguishable for the first 8 to 10 weeks of development. So, we have trimesters. There are 3 trimesters. Every trimester, from the name, is made up of 3 months. So 3 trimesters is 9 months. So the first trimester is about 12 weeks. And those 12 weeks, the first 8 to 10 weeks, you can never tell if the baby is a male or a female. Both are indistinguishable. The female reproductive tract is going to develop from the paramesonephric duct. We talked last week about how the male is going to develop from the Wolffian duct, the mesonephric duct, due to the presence of testosterone. Now, testosterone is not only important for the development of the secondary sexual characteristics, like being muscular and being aggressive and being forceful throughout the challenges of the life that, men being the hunters and the gatherers and the running in the jungle to run after the deer and hunt and bring the food to the family and all of that stuff from back in the day. You see that it was the testosterone that was responsible for those essential male functions. However, not only is testosterone responsible for secondary sex characteristics, it's responsible for the primary sex characteristics. Because if there is no testosterone, there will be no male reproductive tract. There will be no testes descending from the abdomen into the scrotum. There will be no appearance of the penis, no appearance of the scrotum, because it is the testosterone who's responsible for the maturing of these male primary and secondary characteristics. Remember when we discussed the androgen insensitivity syndrome? In androgen insensitivity syndrome, you have a male. That patient who is suffering from androgen insensitivity syndrome, that is not a female, that is a male. What does the karyotype of a patient suffering from androgen insensitivity syndrome tell you? Is it an X and an X? Of course not. It's not a female. It's an X and a Y. You stamp on that. Absolutely, all patients with androgen insensitivity syndrome, absolutely, completely, all of them are X and Y. They're all male. But when you inspect and perform a physical examination of the bodily structure, the anatomy, and the physiology of a patient suffering from androgen insensitivity syndrome, do you see a penis? No. Do you see a scrotum? Of course not. Do you see breast? Oh, yes, you do. So why is that the case? It is because testosterone is present, but the cells that have receptors for this testosterone are not responding. They are insensitive to testosterone. That's why we call the disease androgen insensitivity syndrome. It's supposed to be called testosterone insensitivity syndrome. That would have been a perfect description. But we just settled for androgen because testosterone is an androgen. So the female reproductive tract develops from the paramesonephric duct, not because of the positive action of any hormone, but because of the absence of testosterone and Mullerian inhibiting factor. Without testosterone, what happens when there is no testosterone? The mesonephric duct is going to degenerate, the Wolffian duct. The genital tubercle becomes the glans clitoris, so the clitoris start to form. The urogenital folds become the labia minora. The labioscrotal fold develop into the labia majora. Without the Mullerian inhibiting hormone, the paramesonephric ducts develop into the uterine tubes, the uterus, and the vagina. So it's very interesting. The mesonephric duct is going to degenerate, and the genital tubercle is going to become the glans clitoris. The urogenital folds are going to become the labia minora, and the labioscrotal fold are going to develop into the labia majora, and the paramesonephric duct that degenerated, the paramesonephric duct is going to stay and is going to develop into the uterine tube, the uterus, and the vagina, which are the essential triangle of the female reproductive system. There are internal genitalia for the female reproductive system, and these are the ovaries, the uterine tubes, the uterus, and the vagina. The external genitalia are the clitoris, the labia minora, and the labia majora. And they are found in that diamond shape known as the perineum. The primary sex organs are known as the ovaries. These are the primary sex organs. The secondary sex organs, these are all the organs that are not responsible for the genesis and the making of the female sex cells. The secondary sex organs, these are other internal and external genitalia that are not preoccupied with the primary sex organ, which are the ovaries that make the gametes. So here we see the uterus, this muscular structure, and we see the round ligament is the one that hooks the round ligament is the one that hooks the abdominal cavity with the uterus. And then you see the peritoneum, that pasty layer that covers the inside of the peritoneal cavity. And there's the urinary bladder, and you see the female urethra. And this is the clitoris and the labia minora. This is the labia majora, that's the labia minora, which is more internal. And this is the vaginal orifice. That's the gateway, the entry into the vagina. And you see the rectum. This is the vaginal rugae. And this is the cervix of the uterus. And there is a posterior fornix. This is the posterior fornix. And this is the vesicle uterine pouch. And you finally see the ovaries, the fimbriae, and then the uterine tube. The ovaries are the female gonads that produce egg cells, ova, and the sex hormones. They are almond-shaped structures, and they are nestled in the ovarian fossa of the posterior pelvic wall. The tunica albuginea capsule is a connective tissue that surrounds the testes. We also have a tunica albuginea connective tissue capsule that surrounds the ovaries. The outer cortex is where the germ cells develop. So the inner medulla are occupied by the major arteries and veins, and each egg is going to develop in its own fluid-filled follicle. So during ovulation, there is a bursting of the follicle and the releasing of the egg. So each egg is going to develop in its own fluid-filled follicle. And the outer cortex is where the germ cells develop, and the inner medulla is occupied by the major arteries and veins that nurture that developing germ cell. Each egg is going to develop in its own fluid-filled follicle, and ovulation represents the bursting of the follicle and the releasing of the egg. The ligaments of the ovary. So attached to the uterus by the ovarian ligaments. So the ovary has ligaments that attach the ovary to the uterus. So the ovary is attached to the uterus by the ovarian ligament, and the ovary is attached to the pelvic wall by suspensory ligaments. They contain the ovarian artery, the vein, and the nerves. They are anchored to broad ligament by the mesovarium. So the ovaries are anchored to the broad ligament by the mesovarium. The ovary receives blood from two arteries, the ovarian branch of the uterine artery, which comes from the iliac artery. So you have the iliac artery, and a branch of the iliac artery is the uterine artery, and then from the uterine artery, you have the ovarian branch of the uterine artery. And then you have the ovarian artery. So the ovarian branch of the uterine artery, and then the ovarian artery, which is equivalent to the testicular artery in the males. Ovarian and uterine arteries anastomose along margin of the ovary. So they give off multiple small arteries that enter the ovary. The ovarian veins, lymphatics, nerves also travel through the suspensory ligaments. The ovarian veins, ovarian lymphatics, and ovarian nerves travel through the suspensory ligaments. So here we see the primordial follicles are always in the roof. They are not in the center, because who's in the center? The arteries and the veins. So you see the primordial follicle, the primary follicle, the secondary follicle, the tertiary follicle, then there's a mature follicle, and within this mature follicle, you have your oocyte. The suspensory ligament is going through the suspensory ligament are all of the blood vessels. And finally, you see the bursting of the follicle, and inside the follicle is the ovulated oocyte. Then the remnant follicle is going to be properly disposed of and removed by two separate stages. The first separate stage is known as the corpus luteum, the yellow body. And the final stage is known as the corpus albicans, the white body. And that is the final stage. And these are the fimbriae of the uterine wall. And this is the medulla is in the core, and the cortex is the outer shape. The uterine tubes, uterine tube or the oviduct or the fallopian tubes. It's a canal about 10 centimeters long from the ovary to the uterus. The muscular tube is lined with ciliated cells, highly folded into longitudinal ridges. So this uterine duct or oviduct, known as the fallopian tube, is a canal that's about 10 centimeters long from the ovary to the uterus. It's a muscular tube lined with ciliated cells, highly folded into longitudinal ridges. So we have an infundibulum. This is the infundibulum. As the ampulla and the isthmus. And we have a perimetrium, a myometrium, and an endometrium. This is the internal os, and there's a cervical canal, and a lateral fornix, and a cervical. This is the cervix, and this is the external os. This is the external os. This is the cervix. This is the lateral fornix, and that's the cervical canal. This is the internal os. Then the thick uterus is actually made up of 3 layers in one. There is an inner layer, then there is a middle layer, then there is an outer layer. You remember that when we did the blood vessels. We said there's a tunica externa, that's the outer layer, tunica media, that's the middle layer, and tunica externa, that's the innermost layer. Here also, we have a tunica, but we don't call it tunica here. Here we have this innermost layer is known as the endometrium. Then the middle layer is the myometrium. Then the outer layer is the perimetrium. So the major portions of the uterine tubes, you have the infundibulum, that is a flared trumpet-shaped distal ovarian end. The fimbriae, these are feathery projections on infundibulum. The ampulla is a middle and longest part. And the isthmus is a narrower end toward the uterus. The major portions are the infundibula, there's a flared trumpet-shaped distal ovarian end, and there is fimbriae, that is a feathery projection on the infundibulum. Then there's the ampulla, which is the middle and the longest part. And we have the isthmus, that is a narrower end toward the uterus. So this uterine tube is long. It has an infundibulum, which is a flared trumpet-shaped distal ovarian end. And there's the fimbriae. Fimbriae are feathery projections on the infundibulum. And there is an ampulla. The ampulla is a middle and longest part of the uterine tube. And left the isthmus is the narrower tapered end toward the uterus. The infundibulum is the flared trumpet-shaped distal ovarian end. And the fimbriae, this is the feathery projection on the infundibulum. And the ampulla, then lastly you have the isthmus. The mesosalpinx, what's the mesosalpinx? The mesosalpinx is a superior portion of the broad ligament that enfolds the uterine tube. The epithelial lining of the uterine tube The uterus. The uterus is a thick muscular chamber that opens into the roof of the vagina. The uterus is a thick muscular chamber that opens into roof of the vagina. Thick muscular chamber that opens into the roof of the vagina. It usually tilts forward over the urinary bladder. It harbors the fetus and provides a source of nutrition and expels the fetus at the end of its development. It is a pear-shaped organ. It has a fundus, which is a broad superior curvature. And there is a body, a corpus, middle portion, and there is a cervix, a cylindrical inferior end. The lumen is roughly triangular. It has an upper two corners or openings to the uterine tubes. The lower apex is the internal os. It is not a hollow cavity, but a potential space in a non-pregnant uterus. So it is pear-shaped that has a fundus, there's a broad superior curvature, it has a body with a corpus, the middle portion, and then the cervix is a cylindrical inferior end. The lumen is roughly triangular. The upper two corners are openings to the uterine tubes, and the lower apex is the internal os. It is not a hollow cavity, but a potential space in the non-pregnant uterus. The upper two corners of the uterus are openings into the uterine tubes, while the lower apex is the internal os. So the base of the uterus is at the top, while the apex is at the bottom, just like the heart. It is not a hollow cavity, but a potential space in a non-pregnant uterus. The cervical canal connects the lumen of the uterus to the vagina. Cervical canal connects the lumen of the uterus to the vagina. The internal os is a superior opening of the canal into the body of the uterus. The external os is the inferior opening of the canal into the vagina. It has two osses. The cervical canal connects the lumen of the uterus to the vagina. There's an internal os, that's a superior opening of the canal. And an external os is from the vagina into the cervical canal, that's the external os. And from the center of the cervical canal into the vagina, that is the internal os. The cervical glands, they secrete mucus that prevents the spread of microorganisms from the vagina into the uterus. Because the vagina is closer to the outside, so it's more susceptible to infection, to microbes. That's why it makes a lot of sense that the uterus needs all of these cervical glands to secrete mucus that's gonna trap all of the bacteria and the microbes. The pap smears and the cervical cancer. So the pap smears and the cervical cancer, that shows you the normal cells, and these are the malignant cells. So the pap smears and the cervical cancer. The best protection against the cervical cancer is early detection by pap smear. So the cells removed from the cervix and vagina and microscopically examined. Cells removed from the cervix, the best protection against the cervical cancer. Detection by the pap smear. So the cells removed from the cervix and the vagina and microscopically examined. So there are three grades of cervical intraepithelial neoplasia. So the class 1 is mild dysplasia. Class 2 calls for a biopsy. And class 3 results may call for radiation therapy or hysterectomy. Hysterectomy is the complete outright removal of the uterus. The best protection against cervical cancer is early detection by a pap smear, where you have cells removed from the cervix and vagina and microscopically examined. The three grades of the cervical intraepithelial neoplasia are: class 1 is mild dysplasia, class 2 calls for a biopsy, and class 3 calls results may call for radiation therapy or hysterectomy. The uterine wall is the perimetrium, myometrium, and endometrium. Perimetrium, the myometrium, and the endometrium. The perimetrium is the outer external serosal layer. The myometrium, The myometrium is the middle muscular layer. It constitutes most of the uterine wall. It is composed mainly of smooth muscle, and they sweep downward from the fundus. They spiral around the body, and there is less muscular and more fibrous near the cervix, and they produce labor contractions, and they expel the fetus. So the peritoneum is the external serosal layer of the uterus, and the myometrium is the middle muscular layer. It constitutes most of the uterine wall. It is composed mainly of smooth muscle. They sweep downward from the fundus and they spiral around the body. Is less muscular and more fibrous near the cervix, and they produce labor contractions and they expel the fetus. They sweep downward from the fundus, spiral around the body, the less muscular and more fibrous near the cervix, and they produce labor contractions and they expel the fetus. They compose mainly of smooth muscle and they sweep downward from the less muscular and more fibrous near the cervix. They produce labor contractions. The endometrium is the inner mucosa. That is where the implantation happens. It is simple columnar epithelium, compound tubular glands, and a stroma populated with leukocytes, macrophages, and other cells. Tubular glands and the stroma with leukocytes, macrophages, and other cells. Simple columnar epithelium, compound tubular glands, and the stroma populated with leukocytes, macrophages, and other cells. The functional layer is the superficial half, and they shed each menstrual period, tubular gland, and a stroma populated with leukocytes, macrophages, and other cells. The functional layer is a superficial half shed each menstrual period. The basal layer, the stratum basalis, is a deep layer that stays behind and regenerates a new functional layer with each menstrual cycle. Stays behind and regenerates a new functional basal, the stratum basalis. Stratum basalis, the deep layer that stays behind and regenerates a new functional layer with each menstrual cycle. So during pregnancy, the endometrium is the site of attachment of the embryo and forms the maternal part of the placenta from which the fetus is nourished. Forms the maternal part of the placenta from which the fetus is nourished. This is the endometrial gland. Surface of the uterus is supported by muscular floor of the pelvic outlet and folds of the peritoneum that form the ligaments. The broad ligament has two parts, the mesosalpinx and the mesometrium on each side of the uterus. There is a cardinal known as the lateral cervical ligament. It supports the cervix and the superior part of the vagina extending to the pelvic wall. And there is a uterosacral ligament that attach the posterior side of the uterus to the sacrum. There are round ligaments. These round ligaments attach from the anterior surface of the uterus. They pass through the inguinal canals and terminate in the labia majora. They are similar to the gubernaculum terminating in the male scrotum. The uterine blood supply is important to the menstrual cycle and the pregnancy. The uterine artery arises from internal iliac artery. It gives off several branches that penetrate the myometrium. The uterine blood supply is important to the menstrual cycle and pregnancy. The uterine blood supply is important to the menstrual cycle and pregnancy. The uterine blood supply is important to the menstrual cycle and pregnancy. The uterine artery arises from the internal iliac artery. It gives off several branches that penetrate the myometrium and lead to the arcuate arteries. Each travels in a circle around the uterus. The anastomose with the arcuate artery on the other side. Spiral arteries penetrate through the myometrium into the endometrium. They wind between the endometrial glands toward the surface mucosa, and rhythmically they constrict and dilate, making the mucosa alternatively branch and flush with blood. So here we see, this is the aorta, the abdominal aorta, and from the abdominal aorta you have the iliac, common iliac artery that's going to branch into the external, the one on the outside here, that's the external iliac. And this one here is the internal iliac. From the internal iliac, you have on the bottom, you have the vaginal artery, and on the top, you have the uterine artery. The uterine artery is going to go up to nurture the to nurture the uterus, while the vaginal artery is going to nurture the vagina. The mesosalpinx is very similar to um the lesser momentum and the greater momentum. It's like holding is a ligament that is a tissue that is holding in place the ovaries. And here we see the ovarian artery. The ovarian, there are two ovarian arteries. There's an ovarian artery that's coming immediately out of the aorta, and you have the ovarian branch of the uterine artery. So there's a ovarian artery that goes through the suspensory ligament, and there is the ovarian branch of the uterine artery. Vagina, that is the birth canal. It's an 8 to 10 centimeters distensible muscular tube. It allows for the discharge of menstrual fluid and the receipt of the penis and the semen and the birth of the baby. Other adventitia, the middle muscularis and the inner mucosa. They are tilted posteriorly between the rectum and the urethra. The vagina has no glands, and the transduction lubricates the vagina, which is a vaginal sweating. Transudation lubricates the vagina, that's known as vaginal sweating. The serous fluid through its walls and by mucus from the cervical gland above it. The fornices, these are blind-ended spaces at the top of the vagina that extend slightly beyond the cervix. Transverse friction ridges, these are the vaginal rugae at the lower end, and mucosal folds form the hymen across the vaginal opening. Vaginal epithelium undergoes metaplasia, which is transformation from one tissue type to another. In childhood, the vagina is a simple cuboidal, but in puberty, estrogen transforms it to stratified squamous. Bacteria ferment glycogen-producing acidic pH in the vagina to inhibit the growth of the pathogens. It has antigen-presenting So bacteria ferment glycogen-producing acidic pH in the vagina to inhibit the growth of the pathogens. As antigen-presenting dendritic cells, this is the route by which HIV from infected semen invades the female body. The external genitalia are collectively called the vulva or pudendum. There's the mons pubis, which is a mound of fat over the pubic symphysis, bearing most of the pubic hair. The labia majora is a pair of thick folds of skin and adipose tissue inferior to the mons. Pudendal cleft is a fissure between the labia majoris. The labia minora is a thin hairless fold medial to the labia majora. The space between forms the vestibule, which contains urethral and vaginal openings. Anterior margins of the labia minora join to form a hood-like prepuce over the clitoris. The clitoris is an erectile sensory organ. It's the primary center for sexual stimulation. The glands, the body, and the curva. These are the main structures of the clitoris. There are also vestibular bulbs. These are erectile tissues deep to the labia majora. They are a bracket the vagina. They are a bracket to the vagina. And there's greater and lesser vestibular and paraurethral glands that open into the vestibule for lubrication. That's the labia majora on the outside, then the labia minora, then that's the urethral orifice, and this is the clitoris, and this is the vaginal orifice, and this is the hymen. That shows us also the greater vestibule, paraurethral glands, and the clitoris, the glands. This is the glands, clitoris, and that's the curva. Okay, the breast and the mammary glands. The breast is a mound of tissue overlying the pectoralis major muscle. It enlarges at puberty and remains so for life. So most of the time, it contains very little mammary gland. The mammary gland develops within the breast during pregnancy and remains active in the lactating breast. They atrophy when a woman ceases to nurse. The mammary gland develops within the breast during pregnancy. So it enlarges at puberty and remains so for life. Most of the time, it contains very little mammary gland. Two principal regions of the breast. You have the body, so conical to pendulous with nipple at its apex. Axillary tail has an extension towards the armpit. Lymphatics in the axillary tail are important as a route for breast cancer metastasis. The nipple is surrounded by a circular colored zone called the areola. So capillaries and nerves close to the skin surface are most sensitive, and the sensory nerve fibers of the areola trigger milk ejection reflex when an infant nurses. Breast and the mammary glands is a areolar gland is an intermediate between sweat glands and mammary glands. There are secretions that protect the nipple from chapping and cracking during nursing. Smooth muscle fibers in the dermis of the areola that contract in response to cold, touch, and sexual arousal, wrinkling the skin and erecting the nipple. The non-lactating breast consists mostly of adipose and collagenous tissue. So the breast size is determined by amount of adipose tissue. Suspensor ligaments attach the breast to the dermis of the overlying skin and fascia of the pectoralis major. The ducts branch through fibrous stroma and converge on the nipple. Mammary gland develops during pregnancy. 15 to 20 lobes, there are 15 to 20 lobes around the nipple, and lactiferous duct drains each lobe, and they dilate to form the lactiferous sinus, which opens into the nipple. The ducts end in an acini, and the acini are surrounded by myoepithelial cells. So these are the lobes, these are the lobules, there's the adipose tissue, and these are the lactiferous sinuses. That's the breast of a cadaver, and you see there is a lot of fat tissue. Breast cancer occurs in 1 out of 8 or 9 American women. It is a leading cause of female mortality, and tumors begin with cells from the mammary duct and may metastasize by mammary and axillary lymphatics. So signs may include lump, skin puckering, changes in skin texture, and drainage from the nipple. Contributing causes. You have the BRCA1 and the BRCA2. These are two breast cancer genes. But most breast cancer is non-hereditary. So some breast cancers are stimulated by estrogen. For risk factors, aging, exposure to ionizing radiation, carcinogenic chemicals, excessive alcohol and fat intake, and smoking. So over 70% of cases lack identifiable risk factors. Tumor discovery usually during breast self-examination. That is monthly for all women. So mammograms, which are breast x-rays, they happen in late 30s, which is the baseline for the mammogram, ages 40 to 49 every 2 years, and over age 50 is yearly. Treatment of breast cancer. Lumpectomy. Lumpectomy is the removal of the tumor only. Simple mastectomy is the removal of breast tissue only or breast tissue and some axillary lymph node. So lumpectomy, you just remove the tumor. Mastectomy is remove the breast tissue and some lymph node. Radical mastectomy is the removal of the breast and the underlying muscle fascia and the lymph nodes. Rarely it's the radical mastectomy is rarely done, and it really does not improve the outcome. So it's done as a protective measure, preventative measure, and it's the law. You know, medicine is law. So in the law, if you see a tumor, you're not gonna stand in there looking at it. You have to remove it. And if it went far, we're still going to remove it. Some doctors, which I disagree with, believe that, for the mental well-being of the patient, if the cancer has spread all over the body and it went very far, then no need to remove the entire. That's not true. We should always follow the law and hope for things to improve because they may improve. But you cannot leave the root cause of the breast cancer and you say for the mental well-being. I don't believe in that personally, but you see, doctors have different um methodologies in treating the patient. Breast reconstruction from the skin, fat, and muscle from other parts of the body. So the breast cancer, so you see in breast cancer treatment, so puberty and menopause. So puberty begins at age 8 to 10 for most girls in the United States. It's triggered by Coach, puberty is triggered by rising levels of GnRH, which stimulates the anterior pituitary to secrete FSH and LH. FSH stimulates the ovarian follicles and they begin to secrete estrogen, progesterone, inhibin, and small amount of androgen. Estrogens are feminizing hormones with widespread effects on the body. Estradiol is the most abundant, and estriol and estrone as well. So estrogen are feminizing hormones with widespread effects on the body. Estradiol is the most abundant. P large. the onset of breast development, the earliest noticeable sign of puberty. Arch is different from arch. Arch is the first menstrual cycle. And estrogen, progesterone, and prolactin are going to trigger the development of the ducts and the lobules. Completion of the duct and lobules is governed by glucocorticoids and growth hormones. Adipose and fibrous tissue are going to enlarge the breast. What's pubarch? Pubarch is the appearance of pubic and axillary hair, sebaceous glands, and axillary glands. Androgens from the ovaries and adrenal cortex are going to stimulate the pubarch and libido. Menarche. Menarche is the first menstrual period. Requires at least 70% body fat in a teenager. Improved nutrition has lowered the age of onset to 12. And so if you examine, puberty begins at age 8 to 10. But puberty is not the same thing as menarche. Puberty is the series of developmental changes. So when you do blood work for a girl who's 6 years old and a girl who's 8 years old and a girl who's 10 and 12, you will see that the estrogen level is not the same to when she was 6 years old. So you will see some hormonal, cyclical changes. A girl may have reached puberty long before she had her menarche. So don't think that you have reached puberty when your first menstrual cycle's onset. That's not true. You could have been, and usually you did, reach puberty long before you had your first menarche. So you could have reached puberty at age 8 as a girl, but your first menarche was at the age of 12. That's 40 years. So estradiol, improved nutrition has lowered age of onset to age 12. Leptin stimulates gonadotropin secretion. If the body fat and leptin levels drop too low, gonadotropin secretion declines and the menstrual cycle might cease. So menstruation ceases when the body fat drops below 22% in the adult. So the first few menstrual cycles are anovulatory, no egg ovulate. Girls begin ovulating regularly about a year after they begin menstruating. Why does the body fat need to be at least 17% in order for a woman to consummate her menarche? Or why does menstruation end if the body fat drops to, what's the association with fat? It's the hormone testosterone and the progesterone and the estrogen and gonadotropin. These are all steroid hormones. So they have a receptor inside the cell. Estradiol stimulates many changes in puberty. Stimulates vaginal metaplasia and stimulates the growth of the ovaries and the secondary sex organs, stimulates the growth of the hormone secretion, and increases in height and widening of the pelvis, stimulates the fat deposition in breast, hips, and etc., and thickens the skin. But girls' skin still thinner, softer, and warmer than boys. Progesterone primarily acts on the uterus, preparing it for possible pregnancy. So remember, progesterone pregnancy, progesterone pregnancy in the second half of the menstrual cycle. Estrogens and progesterone suppress FSH and LH secretion through negative feedback. And inhibin selectively suppresses FSH secretion. So hormone secretion is distinctly cyclic, and the hormones are secreted in sequence. What's climacteric and what's the menopause? Climacteric is the midlife change in hormone secretion. It is accompanied by menopause. That's the cessation of menstruation. Female born with about 2 million eggs, climacteric begins when there are about 1,000 follicles left. Follicles less responsive to gonadotropins secrete less estrogen and progesterone. Uterus, vagina, and breast atrophy. So intercourse may become uncomfortable and vaginal infections are more common and the skin becomes thinner. Cholesterol levels rise, increasing the risk of cardiovascular disease. Bone mass declines, increasing risk of osteoporosis. Blood vessels constrict and dilate in response to shifting hormone balances. Dilations may produce hot flashes, spreading a sense of heat from the abdomen to the thorax, the neck, and the face. Hormone replacement therapy, where low doses of estrogen and progesterone to relieve some of these symptoms. Risk and benefits are still being debated. Menopause, the cessation of the menstrual cycle, usually occurs between the ages of 45 and 55. But the age of menopause has increased in the last century. So menopause is considered complete when there has been no menstruation for a year. So this evolution of menopause. So older mother would not live long enough to rear an infant to a survivable age. So better to become infertile and help rear her grandchildren. So this is a theory that why do we have menopause? And the theory says that older women, if they were to be able to have a baby, they may not live long enough to care and rear that infant until the infant survives. So it's better for her to become infertile and raise the babies that she already had than to have babies that she would die and she will not be able to raise them. It's better to become infertile and help rear her grandchildren. Pleistocene or the Ice Age skeletons show early hominids rarely lived past the age of 40. So menopause may be an artifact of modern nutrition and medicine, allowing us to live longer than our ancestors. Okay, so now we're going to talk about the sex cycle. We're going to talk about oogenesis and the sex cycle. The reproductive cycle is a sequence of events from fertilization to giving birth and returning to fertility once again. The sexual cycle are the events that recur every month when pregnancy does not intervene. So the zygote has one of two pathways to choose from, one of two cycles. Either to go into the reproductive cycle, and that is successive series sequela of events from fertilization to giving birth and being fertile again to prepare for having another baby. Sexual cycle are the events that recur every month when the pregnancy does not intervene. So they consist of two interrelated cycles controlled by shifting patterns of hormone secretion. Shifting patterns of hormone secretion. There's the ovarian cycle. So the sexual cycle is divided into ovarian cycle and a menstrual cycle. So ovarian cycle are these events that happen in the ovary, and menstrual cycle are changes that accompany these ovarian cycle in the uterus. So things are happening in two directions, in both directions. So they're happening at the same time, parallel. Oogenesis is the process of producing an egg production. It produces haploid gametes by means of meiosis, distinctively cyclic event that normally releases one egg each month, accompanied by cyclic changes in hormone secretion. So the cyclic changes in histological structure of the ovaries and the uterus. The uterine changes result in monthly menstrual flow. Embryonic development of the ovary. So female germ cells arise from the yolk sac. They colonize the gonadal ridges the first 5 to 6 weeks of development, and they differentiate into oogonia and multiply until the 5th month. So 6 to 7 million in number. They transform into primary oocytes, early meiosis 1. Most of them degenerate or undergo atresia by the time the girl is born. The egg or the ovum, any stage from the primary oocyte to the time of fertilization. So they transform into primary oocytes in early meiosis 1 and mostly degenerate and undergo atresia by the time the girl is born. So the egg or the ovum, any stage from the primary oocyte to the time of fertilization. So by puberty, 200,000 oocytes remain. There is a lifetime supply and probably will ovulate only 480 times. 80 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 times. So the egg development resumes in adolescence. So FSH stimulates the monthly cohorts of about 24 oocytes to complete meiosis one. And each oocyte divides into two haploid daughter cells of unequal size and different densities. They are important to produce an egg with as much cytoplasm as possible. So if fertilized, it must divide repeatedly and produce numerous daughter cells. The secondary oocyte, you would have large daughter cells. So the large daughter cell that is the product of meiosis one. There's a first polar body, is a smaller one that ultimately disintegrates, which is a means of discarding the extra set of haploid chromosomes. The secondary oocyte proceeds as far as metaphase 2, and it arrests until after the ovulation. So if not fertilized, it dies and never finishes meiosis. So if it's fertilized, it completes meiosis 2 and casts off a second polar body. The chromosomes of the larger remaining egg unite with those of the sperm. So the development of the egg, you have a multiplication of the oogonia that produces the primary oocyte. That's before the birth. And from adolescence to the menopause, you have the primary oocyte that would undergo meiosis 1. And once meiosis 1 is completed, we would have the secondary oocyte. And if the polar body is removed, and we would have a secondary oocyte that once it gets fertilized, it will complete meiosis 2 and becomes a zygote. Follicular genesis is the development of the follicles around the egg that undergoes the oogenesis. So primordial follicles, these consist of a primary oocyte in early meiosis, surrounded by a single layer of squamous follicular cells, and follicular cells connected to the oocyte by fine cytoplasmic processes for passage of nutrients and chemical signals. Concentrated in the cortex of the ovary, and they wait 13 to 15 years before they develop further. The adult ovary has 90 to 95% primordial follicles, and the monthly recruitment of about 24 follicles begins 290-day path to maturity that only will finish and about 23 will die. The primary follicles, they are about 140 days into the cycle. Recruited primordial follicles become primary follicles, and they contain larger secondary oocytes at maturing and a surrounding layer of cuboidal follicular cells. Secondary follicles, they appear about 140 days into a cycle. Oocytes are even larger and follicular cells now in 2 or more layers, granulosa cells. The zona pellucida are a layer of glycoprotein gel secreted by granulosa cells around the oocyte. Theca folliculi, connective tissue around the granulosa cells, condenses to form a fibrous husk. Secondary follicles appear about 140 days into the cycle, and oocytes are even larger, and follicular cells now in 2 or more layers, granulosa cells. So the zona pellucida are a layer of glycoprotein gel secreted by granulosa cells around the oocyte. So the theca folliculi are connective tissue around the granulosa cells that condense to form a fibrous husk, that differentiate into two layers. So the theca externa, or an outer fibrous capsule rich in the blood vessels. The theca interna, these are inner cellular hormone secreting layers producing androgens and androstenedione and testosterone, and granulosa cells convert them to estradiol. Tertiary follicles appear about 60 days before ovulation when granulosa cells begin secreting follicular fluid into the small pools. As pools enlarge, they forming a single antrum. Antral follicles, tertiary and mature follicles. Preantral follicles, these are earlier stages of the follicles. Cumulus ovorus is a mound of granulosa cells on one side of the antrum that covers the oocyte and secures it to the follicular wall. Corona radiata is the innermost layer of the cells in the cumulus surrounding the zona pellucida and the oocyte. It forms a protective barrier around the egg with functions similar to the blood-testis barrier. Mature follicles are about 20 days before ovulation. One follicle becomes dominant, the one destined to ovulate, and the remainder are going to degenerate. It captures and holds FSH at about 5 days before ovulation. It is large enough to be considered pre-ovulatory Graafian follicle. The sexual cycle averages 28 days and varies from 20 to 45 days. So hormones of the hypothalamus regulate the pituitary gland, and the pituitary hormones regulate the ovaries. Ovaries secrete hormones that regulate the uterus, and the basis of hierarchy of hormonal control, the hypothalamus, the pituitary, the ovaries, and the uterus. Ovaries exert feedback control over the hypothalamus and the pituitary. So the cycle begins with 20-week follicular phase, and the menstruation occurs during the first 3 to 5 days of cycle, and the uterus replaces the lost tissue by mitosis, and cohorts of the follicles will grow. Ovulation around day 14, the remainder of that follicle becomes the corpus luteum. The next 2 weeks, we have the luteal phase, and there the corpus luteum stimulates the endometrial secretion and thickening. So if the pregnancy does not occur, the endometrium breaks down in the last 2 days. Menstruation begins and the cycle starts over. The female sexual cycle. In the female sexual cycle, we have FSH beginning to increase on the first day of the month up to the third day. And then right when the time to ovulate, you have a sharp increase in FSH as well as LH. However, when the corpus albicans has been formed, there is a severe drop in LH, even lower than FSH in the last day of the menstrual cycle, heading into the beginning of. So these are the ovarian events, the primary follicle, and matching it, you have these increasing amounts of FSH and LH. Ovulation, they reach the maximal point, and then they start to drop until moving from the ovulated oocyte to the corpus luteum and to undergo involution and finally the corpus albicans. The ovarian cycle. So 3 principal steps. There's a follicular phase, ovulation, and luteal phase. So this cycle reflects what happens in the ovaries and their relationship to the hypothalamus and pregnancy. So follicular phase extends from the beginning of the menstruation until ovulation. Follicular phase extends from the beginning of the menstruation until the ovulation. Includes pre-ovulatory phase from the end of the menstruation until the ovulation. So the most variable part of the cycle is seldom possible to predict the date of the ovulation. FSH stimulates the follicles to grow and secrete the estradiol. Dominant follicle becomes increasingly sensitive to FSH, LH, and estradiol. So the dominant follicle has rich blood supply and large number of FSH receptors. So it becomes pre-ovulatory follicle. So the other antral follicles degenerate, go atresia, and the ovary also contains follicles at earlier stages for maturation in the future cycles. Ovulation is a rupture of the mature follicle and the release of its egg and attendant cells, typically around day 14. Estradiol stimulates the surge of LH and a lesser spike of FSH by the anterior pituitary. LH induces several events, so the primary oocyte completes meiosis 1. Estradiol stimulates the surge of LH and a lesser spike of FSH by the anterior pituitary. The LH induces several events where the primary oocyte completes meiosis 1, producing a secondary oocyte and a first polar body. The follicular fluid builds rapidly and the follicle swells. That resembles a blister, an ovary. Macrophages and leukocytes secrete the enzymes that weaken the follicular wall. There's a nipple-like stigma that appears on the surface. So we see here that the maturing follicles secrete estradiol, and estradiol stimulates hypothalamus and the anterior pituitary to secrete FSH and LH. The hypothalamus secretes GnRH, and GnRH and estradiol stimulate the pituitary to secrete LH and FSH, and oocyte completes meiosis 1, and the follicle rapidly enlarges and then ovulates. Ovulation takes place only 2 to 3 minutes. So the stigma seeps follicular fluid for 1 to 2 minutes. The follicle bursts and remaining fluid oozes out, carrying the secondary oocyte and cumulus ovulus, normally swept up by ciliary current and taken into uterine tube. This is an endoscopic view of human ovulation. So the uterine tube prepares to catch the oocyte. It swells with edema. Its fimbriae develop and caress the ovary in synchrony with the woman's heartbeat, and the cilia um, create a gentle current in the nearby peritoneal fluid. Signs of ovulation are the couples attempting to conceive a child or avoid pregnancy may wish to know when the ovulation occurs. So the cervical mucus becomes thinner and more stretchy. The resting body temperature rises 0.4 to 0.6 to 0.6 degrees Fahrenheit. Best measured first thing in the morning before arising from bed. Record for several days to see the difference. Middle shimmers. These are twinges of pain at times of ovulation. So the best time for conception, within 24 hours after the cervical mucus changes and the basal temperature rises. So the luteal post-ovulatory phase. So day 15 to day 28, from just after the ovulation to the onset of the menstruation. So if pregnancy does not occur, events happen as follows. When the follicle ruptures, it collapses and bleeds into the antrum, and the clotted blood slowly absorbed, and the granulosa and the theca interna cells multiply and fill the antrum. There's a dense bed of capillaries that grows amid them, and ovulated follicle has now become the corpus luteum. It is named for the yellow lipid that accumulates in the theca interna cells, now called the lutein cells. Transformation from the ruptured follicle to corpus luteum is regulated by LH. LH stimulates the corpus luteum to grow and secrete the rising levels of estradiol and progesterone. So a tenfold increase in progesterone is most important aspect of the luteal phase. So progesterone has a crucial role in preparing the uterus for possibility of pregnancy. So LH and FSH secretion declines over the rest of the cycle. The high levels of estradiol and progesterone, along with inhibin. So from the corpus luteum, they have a negative feedback effect on the pituitary. So the corpus luteum begins the process of involution or shrinkage, beginning about day 22, 8 days after ovulation. And by day 26, inovulation is complete. And what was the corpus luteum becomes the corpus albicans, small scar. With diminishing ovarian steroid secretion, FSH levels rise, ripening a new cohort of follicles. So ovulation occurs in one ovary per cycle, with the two ovaries usually alternating from month to month. So ovulated oocyte begin ripening 290 days earlier and began the development before birth. Menstrual cycle consists of a buildup of endometrium during most of the sexual cycle, followed by its breakdown and vaginal discharge. So it is divided into 4 phases: proliferative phase, secretory phase, premenstrual phase, and menstrual phase. So the first day of noticeable vaginal discharge is defined as day 1 of the sexual cycle. So the menstrual phase average about 5 days. So proliferative phase is the rebuilding of the functional layer of the endometrium that was lost in the last menstruation. So at day 5 of menstruation, the endometrium is about 0.5 millimeters thick and consists only of the basal layer. So as new cohort of follicles develop, they secrete more estrogen, and estrogen stimulates mitosis in the basal layer and regrowth of the blood vessels to regenerate the functional layer. So by day 14, endometrium is 2 to 3 millimeters thick, and estrogen also stimulates the endometrial cells to produce progesterone. So the secretory phase is when the endometrium thickens more in response to progesterone from the corpus luteum. It's from day 15 to 26, and the thickening is due to the secretion and fluid accumulation rather than mitosis. The endometrial glands secrete glycogen, and the glands grow wider, longer, and more coiled. The premenstrual phase is a period of endometrial degeneration. They represent the last 2 days of the cycle, and the corpus luteum atrophies, and progesterone levels fall, and they trigger a spasmodic contraction of spiral arteries and causes endometrial ischemia, which is interrupted blood flow, and brings about tissue necrosis and menstrual cramps. The menstrual phase, or menses, is a discharge of menstrual fluid from the vagina. It is the first day of discharge, is day 1 of the new cycle, and the average woman expels about 40 milliliters of blood to 35 milliliters of serous fluid. So that shows you the sexual cycle. You have estradiol increasing in the first 14 days. They represent the menstrual phase and the proliferative phase. And then we would have the secretory phase and the premenstrual phase. Endometriosis is the growth of endometrial tissue outside the uterus. That is endometriosis, the growth of endometrial tissue outside the uterus. Growth is often on peritoneum of the pelvic cavity or on the surface of the ovary. So the prevalence is 6 to 10%, is prevalent to 6 to 10% of women, causes pain and sometimes infertility. It is believed to result from a retrograde menstruation or a backward flow of menstrual fluid that exits the uterine tube. So these are the stages of the female sexual response. So from an unstimulated point of view, the uterus tilts forward over the urinary bladder, and the vagina is relatively narrow, and the labia minora is retracted. But when the woman is excited, the uterus stands more superiorly. The inner end of the vagina dilate, and the labia minora become vasocongested, and they may extend beyond the labia majora. The labia minora and the vaginal mucosa become red to violet due to the hyperemia, and the vaginal transudate moisten the vagina and the vestibule. The plateau is when the uterus is tented or erected and the cervix is withdrawn from the vagina. Orgasmic platform, that is the lower 1/3 of the vagina, is going to constrict the penis, and the clitoris is engorged, and its glans is withdrawn beneath the prepuce, labia, or bright red or violet. Orgasm. The orgasmic platform contracts rhythmically. The cervix may dip into a pool of semen, and the uterus exhibits peristaltic contractions, and there's anal and urinary sphincters are going to be constricted. Resolution is when the uterus returns to original position and orgasmic platform relaxes, and the inner end of the vagina constricts and returns to original dimension. Excitement and plateau. So the labia minora become congested with blood and often protrude beyond the labia majora. The labia majora become reddened and enlarged, then flatten and spread away from the vaginal orifice. The vaginal transudate with a serous fluid that seeps through the walls of the canal. The greater vestibular gland secretions moisten the vestibule and provide lubrication. The lower one-third of the vagina constrict, and that is the orgasmic platform. We talked about that. And okay. So in pregnancy, it lasts on average 266 days from from conception to childbirth. The gestational calendar is measured from the first day of the woman's last menstrual period, and the birth predicted 280 days, 40 weeks from the last menstrual period, and determine the duration of pregnancy. And trimesters are 3-month intervals in the term. Conceptus, all products of conception, the embryo or fetus, the placenta, and the associated membranes. Blastocyst, the developing individual is a hollow ball for the first 2 weeks. Embryo, so from day 16 through day 8. Fetus is from the beginning of week 9 to birth, attached by way of the umbilical cord to a disc-shaped placenta. Provides fetal nutrition and waste disposal, and secretes hormones that regulate pregnancy, mammary development, and fetal development. So the neonate is a newborn to 6 weeks old. So the hormones with the strongest influence on pregnancy are estrogen, progesterone, human chorionic gonadotropin, and human chorionic somatomammotrophic, all primarily secreted by the placenta, and the corpus luteum is important source for the first several weeks. So if the corpus luteum is removed before 7 weeks, pregnancy is going to terminate. So from week 7 to week 17, the corpus luteum degenerates and the placenta takes over its endocrine function. The human chorionic gonadotropin, it is secreted by the blastocyst and the placenta. It is detectable in the urine 8 to 9 days after conception by the home pregnancy test kits, stimulates the growth of the corpus luteum, and the corpus luteum secretes increasing amounts of progesterone and estrogen. Estrogens, they increase to 30 times normal by the end of gestation, and the corpus luteum is a source for the first 12 weeks until the placenta takes over. It causes tissue growth in fetus and in the mother, and the mother's uterus and external genitalia are going to enlarge.